When 15 liters per minute of oxygen just isn't enough, a lot of providers don't do a very good job of assessing when they actually need to ventilate the patient. And we'll talk a little bit more about when do you need to ventilate the patient. But the idea is you've really got to do a good job of checking rate and depth, especially rate and depth, to see if they are breathing adequately. Remember that ventilation is the process of in and out. It's the mechanical process of in and out. And oxygenation is kind of an offshoot of when we were talking about respiration. Respiration is just the exchange of gases in the alveoli. So in order to have adequate respiration, you need adequate ventilation. If you don't have adequate ventilation, then you will hinder the ability of gas exchange in the alveoli. Oxygen, when we talk about oxygen, delivering or applying oxygen to your patients by a non-rebreather or a nasal cannula, you're just increasing the concentration of oxygen that they themselves breathe in. So you can help your patient, but the important thing is they have to be ventilating adequately on their own. You can put a ton of oxygen on a mask on your patient, and if they don't have adequate ventilation, then they're not doing a really good job of getting that oxygen down to their alveoli. And then of course, we know that oxygen is only half of the story. They need to get rid of carbon dioxide. So this is entitled When 15 liters of oxygen just isn't enough. And this is from the idea that look at your patient. If they're not ventilating, then it doesn't matter. You can't just put 15 liters of oxygen on them. So these are going to be situations, or really this is a review of ventilation, when we need to ventilate our patient, when we need to apply that artificial ventilation. So before we do that, let's just take a review of the respiratory system and ventilation. Now, we covered all this previously, but this will be a review of the respiratory system. So we remember from the airway chapter and the pathophysiology chapter that we have to have an adequate airway to get air from the outside environment down to the lungs. And so this is just a review of the upper airway anatomy. We remember the nasopharynx, the oropharynx, and the epiglottis and the larynx. Those are all those structures of the upper airway. And this is just another slide that you've seen before, illustrating the nasopharynx, the back of the throat on the above the tonsils, the oropharynx, and this even differentiates between a laryngopharynx. This is just a view when we look into the mouth, into the throat. This is a pretty good view of the larynx, as well as the vocal cords and the epiglottis. Well, not a very good view of the epiglottis, but the epiglottis would be up here, and then of course your vocal cords, and then down here you can see the cartilage rings of the trachea. And then as we move on further down the airway, we get to the trachea and then the whole respiratory tree. We also talk about, when we're talking about airway and ventilation, don't forget we have the parietal pleura and the visceral pleura that make this contact here. So you have the parietal pleura that's going to line the rib cage, and then you have this visceral pleura that lines the lungs. So you really have this space that does not exist until there is air, so pneumo, or blood in the thoracic cavity. So blood would be a hemothorax, air in that chest cavity would be a pneumothorax, and that would actually create a space in that pleura space. And then of course, if you have that, then you have a collapsed lung, and then this lung does not properly ventilate. And this is just some gross anatomy that shows you this. You kind of see this shininess here. You kind of see that visceral pleura, and just the relationship of the lungs as well as the heart and the great vessels. This area is called the mediastinum. You can see the trachea tucked back behind there. The clavicles would come about here. So the apex of the lung is here, and then of course the base of the lung is down here, and then of course we have the diaphragm. This is just to remind us that we have this airway passage. The whole idea is to get air down into these alveoli, and this is a pretty good picture where you have the capillaries surrounding the alveoli. That's where we have that gas exchange. And just another picture of that real spongy appearance of the lungs. You have these very large airway bronchioles, probably some blood vessels, as well as even smaller bronchioles, and then you can't see it, but the rest of this pink tissue would be all the alveoli just stuck together to make the spongy appearance of the lung. And because I didn't say it earlier, here is the carina, where the left and the right bronchus splits off from the trachea. This is a picture of a pneumothorax. It's really kind of hard to see, but anytime you see black on the x-ray, you have air. And you can see here would be the trachea. Here's those large vessels. Here's the heart. And you can see some of the lung tissue here. The problem, though, is all of this right here. That's air. So that is a pneumothorax. In fact, this would be a tension pneumothorax. It's not just air in the lung it's causing collapse of this lung, but it's actually putting pressure into the chest cavity. So we call that a tension pneumothorax, and this needs immediate medical attention by an ALS provider or a physician at a community hospital, for example. You'll definitely need to get this treated as soon as possible, because this is can put your patient into shock, lead to hypoperfusion, and then of course cell death. And this is the treatment for that would be what we call a needle decompression. And I mention this in this slide because a lot of times BLS providers, you may not necessarily hear or understand the terms as we are talking about these types of things. I think it's helpful as we're talking about to actually see a picture of what we're doing. We have that not only a collapsed lung or a pneumothorax, we actually are developing pressure, and what we do is stick a needle in there and relieve the pressure. The lung will still be collapsed, so the patient will probably still be uncomfortable or have some sort of difficulty breathing, but they're not in that shock state any longer, at least from the pressure. When we looked at the pathophysiology of ventilation, we also talked about Boyles Law as it applied to ventilation. So remember that the chest cavity is a closed system. In order to take a breath, we're going to increase the volume of our chest cavity. The pressure is going to get negative, or we're going to create a vacuum, and air is going to rush into our airway, down into our alveoli, and that's how we take a breath, get fresh air down to our alveoli. When we exhale, the reverse happens. Our chest cavity, our chest wall actually recoils back to its original position. So the volume decreases. That's going to increase the pressure, and air is going to be squeezed out, pushed out of our lungs by a positive pressure. So we call normal ventilation a negative pressure ventilation. So if you think about it, we're taking a breath by creating a negative pressure in our chest cavity. So normal conditions, we're breathing negative pressure ventilation. That's going to become important when we start talking about artificial ventilation. Artificial ventilation, we're removing that negative pressure and we're creating a positive pressure. We're squeezing the ambu bag, we're squeezing air into the lungs. It's by positive pressure. So that's going to be important when we start talking about artificial ventilation, the difference between negative pressure ventilation, that's normal breathing, and then positive pressure ventilation is kind of another name for artificial ventilation. So this is everything we just talked about, just in different picture form. Inspiration is active. The intercostal muscles, the diaphragm, they contract. The volume of the chest cavity expands, and we create a negative pressure or a vacuum, so air flows into our lungs. Expiration, the opposite. The lungs and the chest and the ribs recoil, go back to the original position. The volume decreases, pressure then increases, and air is pushed out of our lungs. Don't let that confuse you with positive pressure ventilation, because that's not what we're talking about here. This whole process, the normal breathing is negative pressure ventilation. Even though to exhale we are going to create a little bit of a positive pressure in the lungs. That's not what we're talking about. When we talk about positive pressure ventilation, that means we are squeezing air into the lungs by some sort of means. So just a little review about compliance and airway resistance. Remember that we are trying to make a negative pressure in the chest cavity. Now imagine we have some sort of obstruction, swelling, a foreign body, whatever. We have a resistance to airflow. So we're not going to, our breathing is going to be hindered because we have maybe some airway, we have resistance to flow, we have airway resistance. So if we increase the airway resistance, we are going to have to work harder to overcome that resistance. So you may see that patient using that sternocleidomastoid, really working, using those muscles to really generate that negative pressure to overcome that resistance. So if we have resistance of some form, it could be asthma, so that down in the lower airways we have constriction. That would be a form of airway resistance. We could have an infection in the lung where we have mucus or pus or something like that, that would be inhibiting the flow, the airflow. If we have any of that anywhere in our airway, we're going to have to really work harder to overcome that resistance. And if we start to see that, we're going to start down this process where they may be able to compensate for that increased airway resistance by working harder, but if it continues to increase in resistance, we're actually going to be in a state where we have inadequate ventilations, because that increased work of breathing is no longer going to compensate for the fact that we're having a hard time getting air to flow into the lungs. And as we mentioned, in order to overcome some sort of airway resistance, we're going to have to work harder. And we talked about using these accessory muscles of inhalation. And the one I like to really talk about is that sternocleidomastoid muscle, that big muscle in your neck that you see when somebody's angry or really working hard to breathe. Of course, the scalenes and the pectorals can be involved. But the whole idea is that we're trying to generate a greater negative pressure so we can increase the flow into the lungs. And usually we're trying to overcome some sort of resistance to flow. And resistance to flow doesn't just happen trying to get air into the lungs. We may have a hard time flowing air out, and we may need to really squeeze that air out, almost like toothpaste squeezing out of the tube of toothpaste. We're squeezing the diaphragm and the abdominal muscles to really push that air out of the chest cavity if we have a increased resistance to airflow. So these accessory muscles, if you see someone breathing, they probably have inadequate ventilations, or at least we're going to have to take a little bit closer look. So just to review, so we talked about the airway, we talked about respiration, where that occurs down in the alveoli, and we talked about the mechanics of ventilation. Let's just review minute ventilation, especially as it pertains to ventilation, and this is going to be important, especially when we start to add that skill of bag valve mask ventilation. So we remember that minute ventilation is the amount of air moved in and out of the lungs in 1 minute. So to do that, we take the tidal volume, that's the volume of air breathed in one breath, times the frequency, or you could use the respiratory rate's the same thing. So to get the minute ventilation, what the minute ventilation is how much air is moved in and out of the lungs in 1 minute. So we calculate we figure out the volume of air in one breath times the number of breaths in 1 minute, and that's when we get the minute ventilation. And so if we take 500, a nice average tidal volume, and 12 breaths per minute, we get 6,000 or 6 liters of air in and out of the lungs in 1 minute. So 6 liters in 1 minute. So, and we mentioned that patient that had some chest trauma. We mentioned this in the pathophysiology chapter. We have that patient that's got some chest trauma. He's got some rib fracture. He's got really shallow respirations. His respiratory rate is 30, and his tidal volume is about 200. What would his minute ventilation be? And we remember that it was the same. It was 6 liters per minute. So the same as our normal guy. So we have to consider, though, why is our 18-year-old male with chest trauma, with rib fractures, why does he look horrible, and why does our normal adult with the same minute ventilation, why does he look perfectly normal? So why do they have Why do they have a difference in presentation but the same? And if we remember, alveolar ventilation is, so we take into account the dead space. Remember that the dead space is the air in the airway or the lungs that is not participating in gas exchange. So it's not either in the alveoli or at the very ends of those bronchioles. The air in the alveoli is exchanging gases with the blood. Oxygen is diffusing into the blood, and carbon dioxide is diffusing from the blood into the alveoli. So we have that respiration. Now that air in the trachea, that is not participating in gas exchange. The oxygen molecules that are in the nose, the airway, or the trachea, even the bronchioles and the bronchi and the bronchioles, they're not, those oxygen are staying there. They're not diffusing into the bloodstream. So that is the concept of alveolar ventilation. We have to just look at the breathing or the ventilation of the alveoli, the volume of air that is available for gas exchange. And to do that, we have to remove the dead space from the tidal volume, and then now we can get a better picture of the ventilation for gas exchange. So again, we're going to take alveolar ventilation and minus the dead space. Take tidal volume minus the dead space times respiratory rate to get the alveolar ventilation. And we did this on our normal person, and he had a tidal volume of 500 and a dead space about 150. And a respiratory rate of 12. So we get 4,200 milliliters per minute, or 4.2 liters per minute of air available for gas exchange. All right, let's look at our patient with the chest trauma. There's the calculation again. So he had a tidal volume of 200 minus the 150 times 30 times per minute, and then we're going to get a horrible 1.2 liters per minute. So he is having a harder time getting air down into those alveoli, and the reason is because his ribs are broken. So he's got a structural problem with his chest. He's having a harder time generating the volume that he needs to get air down in his lungs. So the important point of all this, of alveolar ventilation, is really not that you calculate a volume on your patient, because we're not going to know their tidal volume. We're not going to know their specific dead space. We use 150 as kind of an average. We can get their respiratory rate, but it's really for two. We learn this really for two things. The first is that you understand this concept of how breathing works, so you can better assess your patient. And two, you need to assess that patient not just on respiratory rate, but also volume. So when you're looking at your patients, when you're deciding, do I need to ventilate this patient, you need to look at respiratory rate and the volume of air that they move in. And then the third, of course, is going to be, if you are ventilating the patient and maybe they do need a little bit more air, maybe their CO2 is still high, even though you've got a good seal with a mask and you're ventilating, you're not going too fast. If their carbon dioxide is still too high or their oxygen is still too low, it's actually more efficient to give that bag a little bit harder, or not harder, but give them more volume with every breath than it is to increase the number of times you squeeze the bag. I just wanted to take a second just to remind you the difference between hypercarbic drive and hypoxic drive. Remember, our brain stems respond to a increase in carbon dioxide. That's the stimulus to breathe. So in between our breath, our carbon dioxide in our blood is going to increase to the point where we're going to reach a specific threshold in the brainstem, and that's going to be our stimulus to take a breath. So that's hypercarbic drive. Hyper for high, carbic for carbon dioxide. And remember that some patients, this no longer works, either through a chronic disease process like COPD, chronic obstructive pulmonary disease, or maybe even trauma to the brainstem, trauma or stroke to the brainstem. For whatever reason, this doesn't work anymore. We do have a backup mechanism. We have those. We do have some oxygen sensing receptors in our aorta, our carotid arteries, and they sense oxygen, and they sense a decrease in oxygen in the bloodstream, and we're going to call that hypoxic drive. So if the patient, for whatever reason, is no longer, the stimulus to breathe is no longer because of high carbon dioxide, they will have a backup mechanism to breathe in response to low low oxygen in their blood, and that's hypoxic drive. So assessing breathing. So this will be as we continue down assessing our patient. The very first thing we learned last chapter was looking at that airway, ensuring that the airway is open, and we learned different techniques for doing that. We learned different adjuncts, things like that. Now we've looked at we've checked the airway, so we have the airway passageway. Now we need to look, are they ventilating? What is their ventilation like? Are they breathing adequately? Most important question you can ask yourself when you're looking at breathing is, do you need to ventilate or not? So I have Shakespeare here saying, to breathe or not to breathe, that is the question. So we're looking at rate, we're looking at depth, we're looking at how hard they are having to work to generate that negative pressure. We're looking even at regularity. They could have particular types of brain injuries where they're breathing fast or seemingly normal at some times, and then not at all or very spaced out at other times. So look at the regularity as well. So again, to assess breathing, look at rate, depth, look at regularity, look at work of breathing. If they have a little bit of work of breathing, we're probably not going to have to ventilate them, but if they're really struggling to generate that negative pressure, that means we're going to have to give them some positive pressure. If they're not breathing at all, we're going to have to give them some breath. So we'll look at kind of this continuum of when we have to intervene or not. And I call it this respiratory failure continuum. Couple important terms here. We have respiratory distress. All the way over here on this side of the continuum, the patient says, "Oh, I'm having a hard time breathing." They show no signs that they are having a hard time breathing. Remember, dyspnea or respiratory distress or shortness of breath, that's a subjective finding. As the patient has more and more difficulty they might start to show some signs. So they might have some nasal flaring. They might start to use some accessory muscles. So as we move down the continuum, they're starting to show some signs. Another example of that is patients in pain. Pain is completely subjective. We can't measure it. And we ask them to, and we'll learn this later, but we ask them to give us a number, rate their pain. And it might be a 0, it might be a 1. That we can't really see that pain. And even if they say a 10, the 10 is the max. If they say they're 10 out of 10 pain, we can't really see that pain, but we can see them in pain. So we can see them in the fetal position because of kidney stones, for example. We can see them wincing. We can see them really having a hard time because they're in so much pain. The same thing for respiratory distress. They can say, hey, I'm having trouble breathing, and that would be like a 1 on the pain scale. But as they progress, as they have a harder time breathing, we can start to see signs that they are having that difficulty breathing. So you can see things like nasal flaring, increase accessory muscle use, that sort of thing. But the key here for respiratory distress is that they are still able to maintain an adequate alveolar ventilation. And I know that we're not going to be able to calculate an alveolar ventilation on our patient, but it's the concept. Are they still maintaining good oxygenation? Are they maintaining the oxygen level in their blood? And are they getting rid of enough carbon dioxide in their blood? So two sides. And of course, we can measure oxygen, we can measure carbon dioxide, but we don't need to. As soon as we're with that patient, we don't need to put those devices on the patient. Those are great devices to measure their carbon dioxide and another device to measure their blood oxygen. But we don't really need that in the first 90 seconds that we're with the patient. How we do that is looking at rate depth. Rate, is it between 12 and 20? Although some textbooks might give you a little bit more leeway, 10 and 24, that's fine. And then depth. Is it an adequate depth? If it's irregular, I'll tell you that they are not ventilating adequately. And then, of course, as we move down here, we're going to use more and more accessory muscles, and we're going to have more and more difficulty. And we're going to, even to a point where we're having such a hard time getting air in and out to our alveoli that the brain is going to become hypoxic, and then they're going to start to have altered mental status. So we have respiratory distress, but then we get into this condition, respiratory failure. A lot of students think respiratory failure, and you think, oh, their respiratory system has failed. That means they're not breathing. And I'll tell you, that's what respiratory arrest is. Respiratory arrest is no breathing at all. Respiratory failure is any condition that we have inadequate. So inadequate ventilation is respiratory failure. We need to intervene here. We need to do something. If the patient is in respiratory failure, the patient needs more than just an oxygen mask with 15 liters per minute. So I think I have some pictures here, and we'll go through all of those one by one. But again, respiratory distress all the way on one side of the continuum is just, hey, I'm having some difficulty breathing, but they're still able to speak full sentences, they're alert, they're calm. We can slap some nasal cannula on them, and we'll talk about oxygen delivery in another video. You can even give them oxygen by non-rebreather. So of course, as we move down the continuum, they're still working hard. They're gonna work hard to breathe, but they're still breathing adequately. They're still getting enough volume in and out of their lungs. They might need a little bit of extra help, and that would be a non-rebreather mask with some oxygen on them, especially if the cause of breathing is not an increase to airflow, but we have a diffusion issue. We have, for example, a lot of fluid in the lungs, so it's harder for the oxygen that we are getting in and out of our lungs to diffuse. One easy way we can do that is put a lot of oxygen in the alveoli, and then that will help get more oxygen over through that fluid into the blood. So as we move down that continuum, we get to failure. So the patient, they're really speaking, they can only speak 1-2 words. They're having such a hard time ventilating that they can only get 1 or 2 words out at a time. They're very sweaty, they're anxious. At this point, the patient's still conscious, but we're going to have to give them some positive pressure ventilation. And we can do that with a number of means. And we'll talk about each of these, but you see the pocket mask, the bag valve mask, the flow restricted oxygen powered ventilation device, and then we also have this new device, or at least new to EMS. Well, I guess it's not even new anymore, but we have CPAP, and you may have heard of CPAP with you may have heard of CPAP with people with sleep apnea. So it's really just putting a pressure in the airway so that the patient can overcome that resistance a little bit better. We'll talk about that again in a little bit. And then you get into a situation where their brain becomes really hypoxic to the point where they're having some major altered mental status. We're going to have to ventilate that patient, and then they're no longer a candidate for CPAP. You can then bag that patient a little bit easier. I'll tell you, before CPAP, we really had to wait till they got on this side of the continuum before we could ventilate the patient. Even though they probably needed some help over here, it's really difficult to ventilate a conscious patient just by throwing that mask on them. Is anxiety inducing. A lot of patients won't tolerate it, so we would really just have to coach them, give them some oxygen by non-rebreather, and once they really progress to really this level, you can put the mask on them and ventilate them. Maybe they'll tolerate it. But with the advent of CPAP and EMS, we can really target these folks early on. So somewhere on this continuum between they're no longer ventilating their alveoli adequately. So we can't use a non-rebreather, but they still won't tolerate a BVM. So what we can do, we can put CPAP on them, and that's a really amazing thing. And I've seen that patients really benefit over the past 15 years when we've transitioned to CPAP and EMS. And then of course down here, finally, respiratory rest again is not breathing. There's no ventilation. You can't use CPAP. You need to use your pocket mask or your bag valve mask to breathe for that patient. So I talked a little bit about CPAP in there, but what is CPAP? CPAP is a continuous positive airway pressure. It's not so much that you remember what that means, just understand the concept. A lot of people will say it's like a dog sticking his head out the window. You're going down the road at 60 miles an hour, and you can see how the airflow into the dog's mouth is really opening those jowls. And you can think of CPAP in a similar way. A lot of people might think or might tell you that CPAP is really blowing a lot of air down in the lungs, and that's really not true. What is true is that we make a seal with a mask, and it's connected to a hose that is connected to some sort of oxygen delivery device. So it is blowing air when you don't have a seal, but it's not intended to blow air. It's intended to give pressure down into the airway. So remember, the airway is all the way from the mouth all the way down to the alveoli. So if they have some sort of restriction to flow, so they're working hard to breathe, we put some CPAP on them, and then that's going to open up those airways, and then they can breathe in and out a little bit easier. And this is just a device, and we'll do this in lab. So the next time you have lab, you'll see this. It consists of a mask. This particular model has a head straps to make sure it stays on and makes a good seal. And then you have what we call a circuit, or it's just really a hose that goes down to the device. And the device is just designed to put pressure into the mask, and of course it's sealed, so it's a closed system all the way down into the airway. It doesn't hurt the patient. Some patients don't tolerate it because they might feel claustrophobic, and we'll talk about ways to coach the patient to relax and allow it. This is such a beneficial thing. For example, we used to have these patients. Let's say this patient has pulmonary edema. There's two PEs. There's one pulmonary embolism, but let's talk about a different patient, pulmonary edema. So they would have fluid in their lungs, and they might be really working hard to breathe because they're trying to overcome some constriction in their in their bronchioles, and they got fluid in their alveoli, so it's harder for the oxygen to diffuse, and so they're really working hard to breathe. In the past, what we would do is we would try to ventilate this patient with a bag valve mask. They probably wouldn't tolerate it. They're still conscious. They would really work. We'd give them some medications to try to help get the fluid off, but it really wasn't that effective, and they would eventually get so tired that they would go into arrest, and at that point we would intubate the patient. And I tell you, anytime we intubate the patient, either in the ambulance or in the even in the ER, it's a really invasive procedure. They're going to be on a ventilator. They're going to be in the ICU, and they're really at risk for lots of complications, including ventilatory and acquired infections and things like that. So if we're intubating a patient, it's really not good. So about 15 years ago, we started getting these CPAP units in the back of the ambulance, and now we have the same patient, someone who's really working hard to breathe, breathing 44 times a minute. They're not moving any air whatsoever. They're using accessory muscles. They can speak one-word sentences. They're diaphoretic. They're pale. They're really working hard. This patient, 20 years ago, they would get intubated. Now we put them on CPAP, and sometimes it's such a dramatic difference. By the time we get them to the hospital, they're breathing fine, even to the point where the physicians don't believe us. Well, I kind of say that as a joke, but potentially they don't even believe that patient was that sick. And we're like, yeah, they were actually that sick. They would have been intubated, but we have CPAP. So BLS, you guys can do CPAP. That's a great tool in your toolbox if you have a patient that has inadequate respirations. The problem with CPAP is they have to be able to control their own airway. They cannot be vomiting.
They have to be breathing. So if you have an apneic patient or they're in respiratory arrest, you can't use it. If they can't follow command, I would say that CPAP would not be a good tool, and you would have to go ahead and switch from CPAP to a bag valve mask. So CPAP, the indications are inadequate ventilations. However, the patient must be able to follow command. So contraindications, if they can't follow command, you can't use CPAP. If they have active vomiting, you can use it. If they have a pneumothorax, that would not be a time. So you might have inadequate ventilation with a pneumothorax. That would be the only time you can't use CPAP. Respiratory arrest, can't use it. And then hypotension. Remember that the blood goes back to the lungs. The blood goes back to the heart via the vena cava. And if we're adding pressure into the chest cavity, we can actually decrease the cardiac output. In CPAP, we are adding pressure. It's a positive pressure ventilation. We are adding pressure to the chest cavity, so we could potentially decrease cardiac output because we're reducing the preload. So if the patient has hypotension, we can't use CPAP. The other devices that we have, other than CPAP, the other devices we have are this pocket mask, and then of course the BVMs. I'll tell you, they have a continuum, or not a continuum, a hierarchy of what is preferred for ventilating a patient. So other than CPAP, obviously CPAP would be preferred because the patient controls it. It's just adding a little pressure to help the patient. But if you have to ventilate the patient, this is the preferred method, would be mouth to mask. So you have your pocket mask, you put it on the patient, and you breathe into that port. It's a one-way port. It also has an oxygen port, so you can deliver some high-flow oxygen. That is the preferred. And the reason is you do a much better job of ventilating that patient with the mask, with the pocket mask, than you do with anything else on that screen. If you have two people, you have a bag valve mask. You have one person making a seal with the mask onto the face, and you have another patient squeezing the bag, delivering the breath. That's the next preferred. Next is the flow restriction oxygen-powered ventilation device, and we'll talk about that in a minute, what that looks like. And then finally, if you don't have those other three, is one person BVM. And a lot of providers forget this. You'll see a lot of providers, when you have ample help on scene, you'll still see a lot of people doing one-handed seal and squeezing the bag. Remember, that is the least preferred method of ventilating a patient. This is your mouth to mask. You're going to have to stand at the top of the head and deliver the breath. You create a seal with two hands. You could do jaw thrust in conjunction with this. So it's a good option if you need to do C-spine. And then the other is the two-handed, or the two-person BVM, one person doing the seal, the other delivering the breath. And this is the flow restricted oxygen-powered ventilation device. We used to call this the demand valve. The problem with the demand valve of 20, 30 years ago is that we would there was no stopping the pressure. So if we held that button down, we would just deliver a ton of volume into the lungs. The ones nowadays, at least in theory, have a flow restriction to where if you meet a certain volume, it's going to stop the flow so we don't blow the lung, put too much volume in the lung. And then, of course, the final way to ventilate a patient is unfortunately the most common way to ventilate a patient, but the least preferred way is the one-handed BVM technique. Remember that you're using an EC technique. We'll do more of this in lab where we're doing different techniques to provide this ventilation. This is a skill, so the more times you do it, the better you are. But you will need to show that you're proficient in one-handed ventilation, because in theory you could be in the back of the ambulance by yourself and ventilate the patient. So you have to master this technique. The other thing, and this is in your curriculum, is a automatic transport ventilator, an ATV. And this is just one brand, an auto vent, and it's connected to oxygen. It's powered by oxygen. If you ever seen anyone in the hospital on a ventilator, that's not powered by oxygen. That's powered by electricity that turns a turbine that blows air into the lungs. This one is powered by just that high pressure oxygen. And the key thing here is it has different dials. You can select the breaths per minute. You can select, is it a child, is it an adult? And then you can select your tidal volume. Fortunately, we don't do this really in Virginia, but this is on the national curriculum. So let me know if you have any questions.